Hi, this is Dan Mullady. I'm Associate Professor of Medicine at Washington University in St. Louis. And on behalf of my co-authors, I would like to thank gastrointestinal endoscopy for this opportunity to present our data. Our paper is entitled EUS-guided drainage of peripancreatic fluid collections using lumen-apposing metallic stents and double-pigtail plastic stents, comparison of efficacy and adverse outcomes. And while bleeding was one of the initial concerns that we had and initial outcomes that we wanted to look at, we also wanted to look at comparative efficacy of drainage and resolution, as well as other endpoints such as need for unplanned endoscopy. The way we at WashU have typically managed fluid collections is to do an initial drainage regardless of the presence of solid debris or necrosis within the fluid collection, and then only do endoscopic necrosectomy on demand. In other words, if a patient were to come back with fevers, a general feeling of being unwell, or with failure of initial drainage. We found that between the double pigtail plastic stent group, which were 84 patients, and our lumen-apposing metallic stent group, which were 19 patients, that there were equal efficacies in terms of resolution. The resolution that we looked at was at 6 months. The adverse events that we looked at were rates of post-procedural bleeding, need for unplanned endoscopy, and perforation. Between the two groups, there was one perforation in the double pigtail group and no perforations in the LAMS group. The rate of bleeding in the LAMS group was 21%, compared to a 1% risk of bleeding in the double pigtail group. This was statistically significant. In terms of unplanned endoscopies, 26% of patients in the LAMS group underwent interval endoscopy for necrosectomy due to clogging of the LAMS lumen, compared to 10% in the double pigtail plastic stent group. This was not statistically significant, but did approach statistical significance. Interestingly, patients that had LAMS placed, who also had a double pigtail plastic stent placed through the lumen of the LAMS, there were 3 in this group, and none of those patients required interval endoscopy. In terms of an explanation for the increased rates of bleeding seen with LAMS, although this study was not designed to answer that question, we do hypothesize that this may have something to do with rapid decompression of the peripancreatic fluid collection, resulting in intracavitary vessels coming into contact with both the flange of the stent or perhaps exposure to gastric acid. In addition to this being a retrospective study design with relatively small numbers of patients at a single center, our study has limitations in terms of standardization of performing the drainage procedure. This involved whether or not necrosectomy was performed at the time of the index drainage. Within the double pigtail plastic stent group, 4% of patients had necrosectomy at their index endoscopy, compared to 11% of patients in the LAMS group. Additionally, the placement of a double pigtail plastic stent through the lumen of the LAMS was left at the discretion of the endoscopist, and this was performed in 3 patients. In conclusion, our data suggests equal efficacy between double pigtail plastic stents and lumen-apposing metallic stents in the management of peripancreatic fluid collections. However, our data also demonstrated increased rates of bleeding in the LAMS group and approaching statistical significance in terms of requiring unplanned endoscopic procedures. While our data did demonstrate increased risk of bleeding in the LAMS group, we still continue to use LAMS because they are very useful for initial access for debridement and subsequent access for debridement and rapid resolution of peripancreatic fluid collections, and are the only FDA-approved device for this indication. The study was not designed to answer the question of why there's an increased risk of bleeding, but hopefully larger randomized prospective trials will answer this question. Additionally, approaching statistical significance was the need for unplanned endoscopic procedures. Due to the results of our study, if we do not perform necrosectomy at the time of LAMS placement, we've been placing double-pigtail plastic stents through the lumen of the LAMS, which has resulted in fewer unplanned endoscopic procedures. It's possible that the LAMS do such a good job of draining the liquid component of the fluid collection that the solid debris left behind does not have time to liquefy and subsequently drain through. And this may be a mechanism for stent obstruction, and why putting a plastic stent through the lumen of the LAMS may provide a wicking effect for persistent drainage and not having it completely clogged off. Once again, on behalf of my co-authors, I would like to thank gastrointestinal endoscopy for the opportunity to highlight our research through this forum. Thank you.